Everyone. Welcome back to Neurospicy Nursing. Today we're going to be going over the immune response. As promised, I am going to touch on the immune response in the eyes. Um, in a previous video, I had mentioned that if your immune system recognizes that you have eyes, it's actually going to attack it. So we're going to go over that a little bit at the beginning here before fully diving into our immune system, just as more of a bridgeway from that neuro stuff that we went over into this. So, this is a little tip from the American Academy of Ophthalmology, and I really, really implore you to read this. It is amazing about how your um, immune system works and how it sounds very silly, but people who have eyesight were actually very privileged in having eyesight, um, especially because, you know, like I mentioned, if your immune system recognizes that you do have eyes, it's going to try to attack them. So, um, there's also something called immune privilege. I'm going to go a little bit more into in a second here, but it's it basically means that your body, when it goes through that normal inflammatory immune system process, um, it it can recognize, these areas where it's like, oh well, um, we're not going to cause any inflammation there, right? So this is why making sure that your eye health is very important. So there are some other areas where they are also immune privileged, and I'm about to show you guys um, a little photo. All right, so here's the photo I was talking about. So, um, going more in depth into this immune privilege, right? So, think of immune privilege kind of as like a do not disturb zone. It's your body's fully trying to avoid inflammation that's going to be able to damage those very delicate tissues. In the case of the eyes, right? Think of glaucoma, like for the last lecture, especially that closed angle, that rapid increase in intraocular pressure can lead to blindness. So again, that inflammation is damaging that delicate tissue. Our eyes are super duper sensitive, so even just a small amount of swelling or scarring, it can really damage our vision. Think about when you get something in your eye, it's very painful. We have four different nerves that are responsible for our eyeballs, right? So our body, kind of in response to that, we turn down our immune system in order to kind of protect our eyes from overreacting. There's a few other areas in the body that do this. Um, some other areas are going to be the brain. Again, another reason why when we talked about in neuro, it's very important when our brain is under under attack, whether it's from meningitis or some other sort of infection, inflammation, anything that passes that blood-brain barrier, it's concerning, right? And it really requires immediate attention. Um, the testicles is another area in which has immune privilege, and then specifically during pregnancy, our placentas will also have immune privilege. Again, think about medications, right? Like teratogenic medications. Those are medications that can cross the placental barrier. So that's another thing to kind of think about. Um, but our eyes are really the most interesting thing when it comes to the whole immune privilege stuff. So our eyes, they're going to use, obviously we have some barriers to keep immune cells out. Tears are technically a barrier. Our eyelashes are a barrier. Um, Less for immune cells, more for things that are going to cause inflammation, right? But also they have barriers for immune cells. Um, and they use common chemicals, like the transforming growth factor beta. It's also called TGFB or TGF beta. But it's almost like a traffic controller. So they really it tells cells, when to grow, when to change into other types of cells, to heal damaged tissue, to calm down the immune system. And it's part of like our cytokines, right? Where they almost have like a little group chat between the different cells, where they can talk to each other, whether it's about an injury or an infection or inflammation. Um, and so those cytokines, they're really responsible for turning on our immune system. And then the TGF, it kind of blocks it. So it's like almost like think of it like our cytokines. They're trying to get into their favorite club or something, and then the TGF is going to be the bouncer at the door, being like, "Hey, that's not a real ID. You're not allowed to go in there." Um, And then we also have T cells. Again, remember that our T cells are lymphocytes that are produced by our thalamus gland. But these T cells are going to help promote peace. And then the other cool thing about the um, immune system is, or the eyes, sorry, is that they don't actually have lymphatic drainage. So they cause the immune system to have fewer alerts. So the reason why this is so important is because when we talk about eye health, right, and we have individuals who need like a corneal transplant, this is the reason why corneal transplants normally are very successful. It's because of the eye's immune privilege. Um, Also, individuals who have autoimmune diseases, um, even though, autoimmune diseases, it covers your entire body, right? Um, Autoimmune destruction is going to be a little bit less common kind of in the eyeballs, because of this pathway. Um, One thing to keep in mind, though, is because of the fact that we do have a little bit of a quieter immune system when we get infections or tumors, they kind of can sneak up on us really fast, which is why it's really, really important to make sure that we take care of those as soon as possible. And then from an actual like scientific and like medical standpoint, the eyes are really, really important to help with testing for new treatments for vision loss and then some other transplants and autoimmune diseases. But again, just really think about your eyes' immune privilege as like a little protective bubble. Um, and it really helps you protect your vision. But that calm also sometimes accidentally lets some things slip through the cracks, right? So like in the case of like the tumors and stuff like that. So it's really all about having to maintain that balance. Um, so just one more thing to share kind of about this, um, is this little image for you guys. Um, this is just a little cartoon, and it has a little mnemonic on here. I don't know if it's actually considered a mnemonic, but eyes, so these are your immune privilege site. Keep the peace. They suppress your immune responses. No drama. Prevents inflammation that could damage your delicate tissues and just vision. That's our ultimate goal, right? Is protecting our sight. All right, so actually moving into our lecture. All right, so getting into our immune system. So we have two main sections of our immunity, right? So innate immunity is going to be what we're born with. Um, and then acquired immunity is through like passive um things like antibodies through mom's breast milk or vaccines and stuff like that, or getting sick. So our innate immunity, remember I just said that you were born with it. It acts like your body's built-in defense system. So we have our skin, the largest organ in our body. It's responsible for a lot of um, protection against outside pathogens, right? Like if our skin is clean, dry, intact, like no bacteria really should be getting in. And proper hand hygiene too. It's the reason why it's so important. If you have proper hand hygiene, no lesions on anything on your hands, your nails are kept short. You don't have to worry about passing bacteria to yourself, your family, or even between your patients. And then we have the more chemical defense. So that's going to be technically our mucous membranes and those little hairs that we have, like in our nose, um, as well as our entire, like all of our leukocytes, all of our neutrophils, all of those. Once we get an infection, in our body, those are going to help attack those pathogens as well. So, when the first line isn't enough, right? So think about babies, they have the innate immunity, but it's still just not enough to cover them. They get sick very often. And even though, they can bounce back really quickly, they still get sick a lot. So the acquired immunity, its whole thing is to be able to see a target and actually be able to um, fight it like head on as soon as it enters our body. Um, we're going to see this with, things that we get for like vaccines for like Hep A and B. I know as of putting out this recording, today is December 6th, 2025. The United States government, well, not government, technically, but our CDC just pushed out that they're no longer recommending the 24 hours post-birth hepatitis B vaccine um, for anyone who is, after reading the document, it's stating, if an individual does have Hep B or is Hep B positive, we would give that vaccine. But if they are not, then there's no real reason in giving it, and we should postpone it. At this kind of point in time, there's, a lot of speculation, a lot of things up in the air. Um, Obviously, I'm not going to put in my 2 cents, but just know that there are changes to certain vaccines right now as well. And but the entire purpose of vaccinations, and you know, immunoglobulins or any sort of thing like that is to help boost your immune system, right? Yes, getting sick is also going to, boost your technically boost your immune system. Your immune system will recognize that pathogen. However, um, in the case of, like mono or Epstein-Barr virus, any of the viruses, right? Once those are in our system, they're not going to go away. They stay there and they can be reactivated really at any time, which we're going to get into antivirals later. But keep that in mind. So our acquired immunity, it's our body's like little arsenal, right? So we have our active immunity, which is your body has built its own defenses. Sometimes it's also called natural immunity, if we break it down even further. And then there's passive immunity. So that could be from, mom giving breast milk to baby. You get antibodies that way, or through immunoglobulins if you were to have like an exposure. Um, so just some key things to know kind of about your immune system is that the active immune system is that it provides way longer lifetime support than our innate immunity does. Obviously, our innate immunity is going to be with us forever, but it really only covers us for a very short period of time. And then our active immunity, it also has memory, right? So you got sick, we built up antibodies to this illness. if it comes in contact with our immune system again, it's going to recognize it, it's going to fight it off quickly. So this is what I was talking about, natural versus artificial. So natural, you covered from an infection. Um, this says gaining lifelong immunity to chickenpox. Technically, that's true. But just remember, once you have been exposed or and have chickenpox, you're at higher risk of getting shingles, which is why getting that artificial shingles vaccine is really important. Artificial, in this case, there are live vaccines, right? So artificial just it also covers those live vaccines. Yes, live vaccines are technically natural. Um, or like if it was inactivated or toxoid, that's still going to be considered artificial because your body didn't make it. Someone's putting it into you. That sounds weird. Y'all know what I'm trying to say. Right, and then the passive immunity. So again, a little bit of a shorter protection. It's more for like it's almost like borrowed antibodies. I like to think of it, you had a Hep B stick, you're gonna go get your Hep B immunoglobulin just to make sure that you're covered. It doesn't always fully prevent you from getting hepatitis, but it at least can either worsen it if you do get it. So natural mother passing um, antibodies to her child through breast milk, or again, um, immunoglobulins. So here's just a little really know what to call this flowchart of your immune system. I'm breaking it down into the different areas I just kind of talked about. And here's just another one so that you can like visibly see that, okay, the things in green are long term, and these are going to be really strong at the beginning, but they're going to fade over time. So another way to remember is something called IAP, or IAAP, innate active exposure after exposure antibodies made by you, or instant after exposure antibodies made by you or passed to you. So just remember our immune system's super awesome. We talked about how it can recognize that, like, well, I guess technically it doesn't recognize our eyes so that it doesn't attack them, but technically our entire body knows that that's something that it's supposed to do without even us having to say anything, right? Here's some sources I used for this one. Um, just because immunology, it's less from the ATI textbook is where I mostly pulled this information from. Um, so this one was more focused on these sources. Do go and read these though if you are interested. Okay, so moving on to the next portion of this. It's gonna have a little bit of what I just covered. So, this is the innate passive. The one that I didn't talk about like fully kind of is the innate immunity. Um, again, you're born with it, but remember I talked about how it's just very short term. It's technically lifelong, but do note, like specifically note that 3 months is kind of really the capping point of that innate immunity. Adaptive acquired, it has another name, acquired. So that's gonna be that one. It could also be called active. It has like three different names. Okay, so here's just again another chart. I want you guys to make sure that you really keep this in your mind. So I'm trying to put it as much as possible because it is something that, well, one, you're going to see it, when you move on into your other classes, but it's something that people can get confused. And even I literally have one semester till I graduate nursing school, and so I am trying to make sure that learning from my own experience that you guys don't make the same mistakes that I did and in confusing these. I really want you guys to be able to understand them. So here's another chart just kind of going over the active and passive immunities, and then broken them down even further into what's natural and what's artificial. Okay, so moving into anti-parasites first. Anti-parasites, in this case, the ones that I want to talk about is going to be the anti-malarials. So malaria is caused by five species of a very specific parasite. You guys know I can't pronounce things. I'm not even going to try to pronounce that. Where it is actually going to consume the hemoglobin, and then it can lie dormant in our liver. So, fun fact, um, when we're talking about malaria, right? Keep in mind that sickle cell disease was actually our body's immune system attempting to compensate for the malaria. So while it did a really great thing and trying to, compensate, make it harder for malaria to happen, it also did a really bad thing. And, that's how we get sickle cell disorder. And those individuals, unfortunately, will have a lot of chronic pain, spleen issues. They also can have liver issues too. Um, so just keep in mind that um, evol and speaking of evolution, um, we the human body evolved and created sickled cells, because it's your red blood cells, in order to prevent malaria. But unfortunately, um, that did harm. Malaria is going to be more common in outside of the U.S., so Africa, um, the Caribbean, South America. It's very common for malaria to be there. But remember, malaria is from mosquitoes. A mosquito is going to bite you, suck your blood, whatever. And doing that, they're also going to end up putting this parasite in your body kind of through that bite. Um, and then we end up with malaria, which is that breakdown of that hemoglobin. So we have kind of four different medications that are going to be very, very important in this um, anti-parasitic. So we have free radical productions. So these are reactive drugs. They work on free radicals. So you guys who know me know that I have a chemistry uh, and bio background, working in a laboratory setting and clinical setting for cancer. So when we talk about free radicals, it's going to be exactly what you've heard of in the past, with those unstable um, like ions and or elements can also be free radical, but they don't have enough uh, electrons in their shells to make them stable, right? So they need something else to help make it stable. So when we have these drugs that are working on those reactive molecules, what it does is by working on those reactive molecules, it's actually going to damage and then destroy the parasite. After we destroy the parasite, we're going to have to make sure that we target the dormant parasite, because there are dormant parasites that stay in your liver. It's almost, I like to think of it like tuberculosis. You have latent and active tuberculosis. So our latent, quote unquote, latent malaria, it's in our liver. And then at any point in time, you can have relapse. Um, okay, so there's also meth mefloquine. I don't know if I'm saying that, I'm so sorry. But this is more of a prophylactic agent. Obviously you can use it when you have an active malarial treatment. But if someone's going out of the country, and they know that they're going to an area where malaria is going to be very high, they can give them this drug. One thing to keep in mind with this drug, though, is that, unfortunately, um, if an individual has a past medical history of anxiety and depression, or if they're medicated for anxiety and depression, this is not a medication that we can give. It's contraindicated in these individuals because of the risk of, that increased anxiety, increased depression, and then even psychosis. Um, the other one that you need to know is the mitochondrial folate inhibition medications. So, hydrochloroquine. We've talked about it before. It's a DMARD. But um, this works by actually inhibiting the production of folate in the parasite, which then is going to interact with the mitochondria and the functionality of the mitochondria inside of the parasite. And then by doing that and affecting both of those pathways, the mitochondrial pathway as well as the folate pathway, we're going to prevent the reproduction of the parasite in the body. All right, so this is what I was talking about when we talk about mefloquine. Some other ones that to keep in mind with this medication is also the risk of an increased risk of seizures. So if we do know that they have epilepsy and are managed, but maybe still have breakthrough seizures or completely, I don't want to say unmanaged, right? But like are having continuous breakthrough seizures. It's not really regulated. This is not something that we're going to give them either. I mean, like cardiac issues, it's also one of those medications that's going to prolong the QT interval. And we're going to talk a lot about what a QT interval is. I know we mentioned it a little bit when we went through the GI system, but I'm going to talk a lot about what a QT interval is in the cardiac lecture. And then for hydrochloroquine, remember it is that medication that's used in lupus and in also can be used in RA. But don't forget that it can lead to vision changes. Even though it, suppresses, I'm giggling because hydrochloroquine suppresses your immune system. But because of the suppression in immune system, it's almost like it recognizes your eyes and that can cause vision changes. Um, and then just generally, for anti-malarials, ototoxicity, hemolysis. So the destruction of the red blood cells. Again, I talked about sickle cell disorder. Hemolysis is very, very, very common in sickle cell disorder. And here we kind of see a little bit of it. We can kind of see the thought process of like the evolutionary trait of the sickle cell disorder. But again, it just didn't work out as planned. We really should be telling these patients to make sure that they are taking the full course. That way, the parasite fully gets out of their liver, and then they hopefully don't get a relapse of malaria. And then if they are going out of the country, prophylactic medications to start 2 weeks before their trip, and then they can take this with food to prevent upset of the stomach. So this is going to be just very basic, kind of a little bit about antiretroviral um, medications and AIDS. A little bit later in this lecture, I'm going to go way more in depth into this because I want you guys to really make sure that you understand this and see how important it is. So AIDS, it's a virus. It's going to attack certain helper T cells called the CD4s. By doing that, it's going to weaken the immune system. And then AIDS is the progression of an untreated HIV infection. Um, not they're not two separate diseases, right? They are the same disease. One is just it has now progressed. And that progression is going to be all based on the CD4 count. A normal CD4 count for a healthy individual, an individual who is U equals U, um, not immunocompromised or doesn't have HIV is going to be from 500 to 1500 cells. Um, other other things I want you guys to know is when we talk about HIV, it's a very sensitive topic, right? Please make sure that you guys are also being cognizant of how you speak to your patients with HIV. Um, it, like, and I mean that in the sense of, we've gotten very good at saying, someone lives with substance use disorder, right? Instead of saying, oh, so and so is an addict or an alcoholic. They live with the substance use disorder, um, or they live with alcohol use disorder. For these individuals, they're living with HIV. HIV doesn't have to become AIDS. HIV is not a death sentence. Um, there are treatment options available for it. And they can live normal, healthy lives. And we really should not be um, putting them in any boxes. And we should not be, um, all in all, let me just say that it is very important when we're talking about HIV because of how sensitive the topic is to not make any assumptions about the character or the individual, your patient. Just because they have HIV does not mean that they were being reckless, does not mean that they were doing something that they are not supposed to be doing or is against maybe your values or something like that, right? That's another thing to keep in mind. Okay, so just a little bit about this prevention. We have PrEP, so these are people who are considered high risk individuals. You have to have an HIV negative test to be able to start. So people who already have an HIV positive partner, MSMs, or individuals with multiple partners, sex workers, people who may also share needles, but it's a daily medication. And then PEP is going to be an emergency regimen to prevent HIV. This has to be started within 72 hours, but obviously the sooner it happens, the better. The better kind of prognosis slash chance you have of not developing HIV. But these are going to be from, unfortunately, sex trafficking victims, needle stick injuries, especially in healthcare, sexual assault victims, and other individuals who have been put in high risk exposure. So this is going to be a 28-day course, and it has some different art drugs. Um, which is antiretroviral therapy, but it can feel relatively severe, right? Like they may feel like they're on the flu, like have the flu on steroids. Um, but just make sure that you tell them, hey, it feels really bad right now, but in a few days it's going to get better. Just keep taking the medication because it's going to prevent any of you getting the virus. And then art therapy. So again, I do have a whole PowerPoint kind of on HIV and art therapy, but I'm just trying to get you guys a little bit exposed to it. So um, you guys are kind of prepared for that once I go into it. So art therapy, the whole purpose of it, right, is to prevent progression to AIDS. Um, The other really cool thing about art therapy is that it can reduce your viral load to undetectable levels, which means if your U equals U, and U equals U means um, undetectable equals untransmittable. So these individuals have to be undetectable for a certain amount of time in order to get that untransmittable, that this U equals U status. But that's really what art therapy does. It also is going to improve an individual's CD4 count to help with that immune function. And then again, it's going to prevent the transmission of HIV. So they have a several different medications that they're really going to take almost every single day. I'm gonna say every single day. Um, and it's really a very strict, you know, adherence. Um, and just because you become U equals U does not mean that you no longer have HIV. Again, it's a virus that's going to stay in your body for the rest of your life. So this is a medication that's lifelong, these medications. So with the strict adherence, a a good portion of that is to kind of help prevent the virus's ability to become resistant to that. All right, now going into some of our antibiotics. Um, Again, we've got a lot of them to go over. Um, but we have bactericidal and bacteriostatic. So penicillin, cephalosporins, aminoglycosides, zinc, and fluoroquinolines, they're all going to be bactericidal, which means that by itself, this medication is directly lethal to a pathogen versus bacteriostatic like tetracyclines, macrolides, and sulfa drugs. These ones are going to prevent bacteria from multiplying, and then it's going to help kind of clear the immune system, or clear the immune system from the infection. Um, Another thing to note kind of about um, bactericidal versus bacteriostatic, or I mean, not really kind of just about that, but antibiotics, right? Um, they are sometimes given in combination with each other. I just didn't ask this question the other day, and they asked why. So when we give combo antibiotics, what we're trying to do is make sure that we fully get rid of that pathogen, right? Like we want to make sure that it's fully eradicated. And a lot of times when we do combination for the bacteria, it could also be because maybe they are a relatively resistant bacteria. Um, so with that, the other thing to note too is that technically using antibiotics should help reduce chance that the bacteria is going to adapt and survive in side of an individual's body. Um, like if we have like a multi-drug resistant organism, like C. diff or like technically MRSA is only resistant to like one, but C. diff is a really good example for broad spectrum antibiotics. But um even though it's supposed to help prevent resistance, it can also cause resistance if individuals aren't taking the antibiotic correctly, which is why we have to make sure that we tell people, take the full course of antibiotics, because it's going to really make sure that that bacteria um, dies off, doesn't become resistant to that. You don't want to just stop taking antibiotics when you stop getting all of the signs and symptoms of your infection because it could still be in your body. Um, the other thing it's going to do is it really broadens the coverage. So some doctors may prescribe a bactericidal and a bacteriostatic, and then by working together, it's going to make sure that that bacteria again it gets killed off. Like in the case of E. coli, um, it has something called beta lactams, and then like aminoglycosides. They are um, relatively good um, with targeting that pathogen in certain infections. Um, and then again, for the whole like polymicrobial infections, so multiple bacteria, um, they may need multiple different antibiotics to target each type of bacteria that they have. And then hopefully, because of the fact that we're using multiple medications, they don't have to be on such an intensive dose of one medication. They could be on a little bit lower of a dose, and then that could help lower kind of the risk for toxicity, because they're taking two different like medium level antibiotics versus one really high level antibiotic, if that makes sense. Okay, so going into all of the mycins, because we've got aminoglycosides, macrolides, and bank all end in myosin. Um, So the aminoglycosides, again, these are bactericidal. These are going to be your streptomycin and your gentamicin. These can cause kidney damage. They're going to damage your hearing, and they're technically neurotoxic. So you can get peripheral neuropathy type symptoms, and then you can also be a little bit confused. They're also teratogenic. Macrolides, so azithromycin, erythromycin, um, these ones can prolong that QT interval. Again, I'm going to talk about what a prolonged QT interval is. I know you guys have heard me say that a lot, and you're just like, I don't, like, what is that? Um, they're also hepatotoxic, so these are really going to be the medications that you want to make sure that you tell these people don't take it with alcohol, um, even up to about 3 days after they're done with their course of antibiotics to try to avoid alcohol. Attempt to avoid Tylenol if you can. Obviously, if they have a fever, Tylenol um, is better for fevers unless they have a pretty high, a lot higher of a grade fever than ibuprofen works really, really well for fevers. But um, just try to avoid Tylenol because of the risk for hepatotoxicity. Um, Vancomycin. So we do have an infusion-related reaction here. You can see it as vancomycin flushing syndrome, or it's also been called Redman syndrome before, but it's caused by the rapid infusion of this medication. So the first thing that you're going to do if you ever see, flushing, and a patient who's getting vanc, you're going to stop it, and then you're going to notify the provider, because the if you don't know whether or not they're having an allergic reaction, like maybe they don't have like full-blown angioedema, like their airway doesn't seem compromised, but you're unsure, it's okay to pause it, have the provider come and assess the patient, because they'll just restart the infusion if it is not a allergic reaction and it's not something that they need epi for. They'll just turn it back on and tell you to slow it down if it's just like Bredman syndrome. Um, Other things it could do, it's nephro and ototoxic, very similarly to the aminoglycosides, but it requires peak and trough monitoring to make sure that we're not below a level in which it's not going to be, you know, killing off the bacteria. But again, since it is so aggressive and toxic, we're going to make sure that it's not above 15 so that it's not doing any damage to the body. Um, Vanc is very aggressive on our vascular system. Um, you can obviously enter it peripherally. There is just a preference because of how aggressive it is to do it in some sort of central line because again, that vasculature is a little bit bigger than little meemaws, little very narrow AC vein, right? So that's another thing to keep in mind is making sure that you're really looking at that IV site. Is there any infiltration? These are stuff that we're monitoring for. So, fluoroquinolines. These are our floxacins, the N-floxacin. That's going to be our suffix for those. These ones have a adverse effect of a tendon rupture. So for some reason, the tendon is going to shrink, and then it leads to drop foot. And then so drop foot means that like your toe is pointed down and it's kind of stuck there. That tendon becomes very stiff. After that tendon has become very stiff, an individual's still going to walk on it. They're not going to think much of it, but walking around on it, moving it around, it's since it's so stiff, can lead to the rupture of it. It's very common. It very commonly happens in the Achilles tendon. Um, so any sort of tendon area, especially in that Achilles tendon, heel pain, stuff like that, they need to report that immediately. Some uses that we have for fluoroquinolines are going to be osteomyelitis, so the infection of the bone, UTIs, and it can also be used prophylactically. All antibiotics can be used prophylactically, for the most part. I don't think someone would get bank for prophylaxis. But one of the reasons that we're going to use antibiotics for prophylactically is going to be if they have a past medical history of like
I'm sorry, infective endocarditis, so inflammation kind of an infection of the heart tissue. Pericarditis is another reason, or if they have a past medical history of joint replacements, is another reason why we're going to do prophylactic antibiotics, especially before dental treatments for these individuals. Um, we're going to do it for that. So tetracyclines, um, they have very similar to some other medications that we've heard about in the past. They have to be taken upright with a full glass of water because of the risk for pill-induced esophagitis. The other thing that tetracyclines do is can permanently stain your teeth in children. So we try not to give these to kids if possible. As well, it's not like fully, I wouldn't say it's like fully teratogenic. We just, if we really try not to give pregnant moms this medication because of the fact that it can cause permanent tooth discoloration, because it can kind of cross that placental barrier. And then same thing with little kids, you know, permanently discolor their teeth. Um, Increased sensitivity to sun. So these individuals are at a higher risk of developing skin cancer while on this medication, especially if they have to take it for an extended period of time. It's also not great with oral contraceptives, so they have to be using some second form of birth control. Sulfa drugs, so they have that adverse effect of Stevens-Johnson syndrome. So like that peeling and blistering rash that individuals get on their skin. Um, so sulfa drugs like Bactrim, they actually have a cross sensitivity with thiazide diuretics, so hydrochlorothiazide, as well as furosemide, which is Lasix. So if you are allergic to those, you may be also allergic to the sulfa drugs. They are going to block folic acid, so um, patients have to make sure that they are increasing their intake. It can also cause dehydration, and it can lead to kidney stones. So cephalosporin, um, and penicillins. So for penicillin G, it's the first line treatment for um, syphilis in pregnant women. So even if they have a known allergy to penicillin, we would just give them Benadryl or heaven forbid if it's a severe allergy, put them on like an epi drip while they're getting their penicillin G to do some desensitization to help treat that syphilis. Um, the cross sensitivity, so it's always mentioned that there's a cross sensitivity between penicillin and cephalosporins. And yes, it's true, but it normally occurs really in like less than 2% of individuals. Um, it's less related to like the beta lactam rings, which I'm not gonna don't know what it is. I think it's really not that deep. But um, it's more because their side chains are very similar to each other and not actually the ring. But later generation cephalosporins, generations 4 and 5, there's 5 different generations of cephalosporins. They're going to be a lot safer for those with a penicillin allergy than those take like if they were to take an earlier um, cephalosporin. So going into TB, again, remember TB, it is can be both active and latent. So if someone has a um, skin test, that came out positive, also keep in mind that some medications can actually cause uh, the TB skin test to come back positive, even if they don't have like active or latent TB. So the best way to see is one, obviously ask them what medications they're on, And then if they have a medication that you know that's going to cause an active or a false positive on the skin test, it's probably better to do the quantiferin blood test on that individual. And then for TB, on top of the blood tests, the blood tests, um, you're also going to do a chest X-ray to actually see um, whether or not they have active tuberculosis. Tuberculosis is going to be one of those things that can be um, forcibly treated by the public health department if you do have an active case of tuberculosis. And then when these individuals are in the hospital, they're going to be in a negative pressure room. All right, so going into the drugs for tuberculosis, we have rifampin, which can actually turn your bodily fluids an orangey red color. So if these individuals wear contacts, you have to make sure that you tell them, hey, you should be wearing your glasses because this is gonna cause staining in your contacts. And then these individuals have to get their LFTs monitored. Iso isoniazid, can't pronounce it, sorry, but one of the key side effects in this medication is going to be peripheral neuropathy. Taking vitamin B6 can really help with that peripheral neuropathy, but that's just something to keep in mind. And again, hepatotoxic, so no Tylenol or alcohol. And don't forget that all these medications are taken in combination with each other at the same time when someone has TB. So the P is going to stand for urazinamide. They have a side effect of hyperuricemia, so increased um, uric acid in the blood. And obviously if it's prolonged, they can end up with gout. It's also hepatotoxic. And ethambutol, it can cause optic neuritis, so the inflammation of the optic nerve, your immune system can see you high. And these individuals have to make sure that they are reporting vision changes. So antifungal, and antiprotozoal. So nystatin, very important for oral thrush. I talked about, our patients who have methotrexate. Uh, the Candida bacteria causes the oral thrush. It, like I mentioned, it looks like milk, but you can't scrape it off. And if someone has asthma, it's very common for them to get it from their steroidal inhaler. People who chronically take prednisone as well can get that. So when we're using the antifungal, they have to squish it all around in their mouth, get all the surfaces in their mouth um, very, very thoroughly, and then swallow that medication. You really don't want to spit out nystatin. It's better to swallow it so that way it gets all the way down because that, in fact, that fungus can go all the way down your throat into your esophagus. It's gonna though cause malabsorption of potassium and magnesium, so make sure that you're monitoring their electrolytes. Um, Amphotericin B, it's another fungal infection. It can actually be used for fungal meningitis, and it's a pretty intense drug. It's pretty toxic and has a pretty high risk of nephrotoxicity. And ketoconazole, that's a topical agent that's used for like dermatitis. And then we have flagyl. So we use it a lot in C. diff, BV, um, and when people have worms. Make sure though that if they're taking flagyl that they don't have any alcohol. And again, 3 days after they're done, no alcohol either. So super infections. So um, some examples of super infections are listed below. C. diff is really, really common, especially in our hospitalized patients. But since these antibiotics, all of them, they're taking out or removing all of our um, good bacteria along with the bad bacteria. But some opportunistic infections, they'll take advantage of the fact that you don't have any more good bacteria, and then they're going to go and proliferate in the body. So that's what creates super infections, and super infections are also you know, resistant to certain antibiotics, or all of the antibiotics in some people's cases. Again, don't forget that when are doing any of these, a culture is required first to figure out what it is, and then to figure out the treatment for it. So, improper prescribing of these medications can cause um, these super infections. Like if they need a narrow spectrum and you give them a broad spectrum, it's another reason why. And then patients not completing the full course um, also allows resistant bacteria to multiply. Now it's resistant to the bacteria they just took, so they're inadvertently um, causing some of them are causing inadvertently causing super infections. Okay, so just remember, um, you know, obtain your cultures before you start your antibiotics, and make sure you identify what the pathogen is sensitive to. Um, Try to steer away from always prescribing, which you guys are going to prescribe, but always using broad spectrum antibiotics if they're not needed. Make sure you're educating your patients on signs and symptoms of, toxicity, further infection, or allergic reaction. A lot of people for penicillin, um, they'll say they are allergic to it, but the allergic reaction was just like a stomachache, which is normal in penicillin, right? So they may not actually be allergic to it. And then remember, the biggest thing to help promote or to prevent these things is going to be hand hygiene, vaccinations, and using probiotics. All right, now we are going to go into this right here, our full kind of HIV lecture. So again, just reiterating, we have innate immunity, and then we have our adaptive immunity. So B cells and T cells, they are part of that adaptive immunity, and we're going to see and learn more about, those coordinated T cells. So, going over the CD4 cell. So the CD4 cell is a type of white blood cell, and it's very important for our adaptive immune system, right? So the normal range I talked about was 500 to 1500. Um, but um, it's going to act kind of like as the coordinator, right? Like I had mentioned, acts like the coordinator for our entire adaptive immune cells. So it's going to signal our B cells to help make antibodies, and then it's going to activate those cytotoxic um, T cells to help kill off the infections, and then they recruit macrophages, which kind of absorb and then destroy the pathogens. And so without the T cells, it's really not going to be able to have such a coordinated defense against bacteria and other infections in our immune system. So, um, HIV, it's a retrovirus and it's going to attack your body's immune system. And even though it doesn't attack, like some people may think that it attacks discriminately, it's obviously, not trying to. Um, it's just that certain individuals are going to be higher risk based on, unfortunately, their race and their um, gender as well, um, and sometimes even, the location in which they live. Um, so, uh, the whole point of the of HIV is going to infect and destroy um, the CD4 cells. Um, its whole thing is about taking out that main leadership. So for HIV and how it affects our CD4 cells. So it's going to bind to the surface of our CD4 protein, and then it's going to be able to get kind of through the membrane, and then it's going to inject the RNA for HIV into the cell. The cell is then going to replicate that, and then it's gonna you know it should. I'm trying not to get very sciencey into that because I used to work with you know RNA and DNA very frequently, and I'm not trying to overload you guys with that information. Um, it is going to convert DNA into RNA, and then it's going to integrate it into the host's DNA. And then after that happens, it leads to the destruction, of the CD4 cells. So, since HIV is, kind of rapidly destroying our CD4 cells, it's going to cause our viral load to increase, and then it's going to decrease our CD4 count, and this is what causes the progression to AIDS. So again, the progression to AIDS, it's going to be below a CD4 count of 200. Is really what can it's really anyone who is, severely immunocompromised. They have a low CD4 count, but in AIDS, in HIV to progress to AIDS, it has to be below 200. And so now at this point, these individuals are going to be at higher risk of getting opportunistic infections, like Kaposi's sarcoma, cytomegalovirus, stuff like that. So here are some very common opportunistic infections that an individual with HIV can get. So this is Kaposi's sarcoma. It is a cancer, but it's a not very opportunistic one. This pneumonia, it is actually very common for individuals with AIDS to pass away from this type of pneumonia. And again, HIV and AIDS, they themselves are not the cause of death. These opportunistic infections are. So, with art, I mentioned a little bit before how it helps suppress the HIV replication in the body. It's going to preserve our CD4 cell count, reduce our viral loads, and then prevent the progression of AIDS. So, in order to prevent the progression and prevent resistance, it's going to be a combination of three different drugs. Since HIV can mutate very quickly, and it can also itself create, because it is virus drug resistant strands, it's very important for a single drug to just be seen by the virus and then it become resistant to it. So by attacking it at multiple points, kind of just like how I mentioned with the antibiotics and why we give multiple of them, it makes it virtually impossible for this virus to mutate and escape. Now, is it possible? Of course. Yeah, of course it's possible. But if they're taking it properly and they're ensuring, they're sticking to a very strict schedule, it it's not going to end up mutating. It's not going to escape. And then it should be suppressed long term. So again, we have to make sure, and I really don't like this word non-compliance because a lot of times people are like, well, I didn't really understand what I was kind of getting myself into. So you have to make sure that you're educating your patients. Someone can't be considered non-compliant if they don't know what's going on, or they don't understand what they're supposed to be doing. So for non-compliance, that viral load is going to rebound very quickly. Our CD4 count is going to drop, and then you have drug-resistant HIV mutations, and then the immune system is going to weaken and cause progression to AIDS with the presence of opportunistic infection. But with art, the whole purpose of it, again, suppressing that viral load, make it to undetectable levels, recover that CD4 count, and then prevent the progression of AIDS. People with undetectable equals untransmittable, that U equals U, they cannot sexually transmit HIV to other people. So if they wanted to, they didn't have to use condoms. I still think that, people should, but they didn't have to. HIV positive mothers who are U equals U can breastfeed and can deliver vaginally without having to worry about transmitting HIV to their child. And something that's awesome about, this art therapy is that because we can get to this U=U status, it really reduces the stigma and can help empower individuals who do have HIV, who are living with HIV, um, to, feel like this isn't going to be a death sentence for them. So this is kind of the new equilibrium after an individual has started art therapy. And within about a year, hopefully, of them taking it, they should reach this kind of undetectable level, and be in a healthy CD4 count range. All right, so um, this is more about our immunity. So you guys can read this. We've talked a lot about this, but it's in relation to HIV. So innate immunity, obviously, this early defense is going to be bypassed. Our adaptive immunity is crippled by HIV, because again, it's destroying those CD4 cells. It's lowering that immune system count. And then passive, it's not going to do anything in relation to HIV. All right, so overall, CD4 counts, they're going to be our commanders for our adaptive immunity. AIDS is when our CD4 count is less than 200. ART is to help suppress HIV and preserve our CD4 count. Non-compliance with ART is critical and can lead to viral load rebound. And then U=U, undetectable equals untransmittable. And then the last section of this is going to be this preoperative, just because, when we're thinking about infection control, um, and our immune system, preoperative is kind of going to get into that. So, we should be just overall providing evidence-based care, prioritizing our patient safety, working on our communication always. All of us can be better communicators, even if you think you're the best one. Applying the nursing process through all of the phases, advocating for your patients and your families, and to hopefully promote cost-effective care. So we have three stages of the surgical journey: preoperative, intra, and postoperative. They really sound exactly like what you think. So things that we need to know about the surgeries: is it going to be a major or minor surgery? Is it elective, urgent, or emergent? Remember, for urgent and emergent, urgent is like, okay, this is bad, but like it's not really at like life or death yet. And then emergent is, they're about to, like, we don't get them to that OR. This is bad. So the purpose of it, we can have diagnostic ones, like if they were doing like pulling out a bunch of tissue for a biopsy, ablative, palliative, reconstructive, cosmetic, and procurement. So, for the surgical risks, make sure that for the post-op nausea vomiting, this is when we would give that like cyclopamide patch. For obstructive sleep apnea, I'm going to talk a lot more in our sleep lecture, but it does increase the risk for uh, post-surgical complications. For nutrition, immunosuppression, smoking increases your risk of atelectasis, and age can also affect it. So, for the first part of the surgical client, you have to make sure that you're getting their health history, their lifestyle, that psychosocial history, and then you're gonna also potentially have some cultural and spiritual beliefs. Like if it comes to blood products, a Jehovah's Witness would decline that if that was something that they had to sign for their surgery. For the physical exam, some providers may have to physically check off a patient and say that they're good to go for surgery before they have it. So make sure, a lot of people get very anxious before surgery, and you know, the surgery puts people at risk for infection. So things that we're going to do is, make sure that you are having them sign their consent before any sort of sedation is given. Um, Make sure that they're NPO and they only took the medications that they're supposed to take before coming in. And then the biggest thing is hand hygiene, or just not hand hygiene, but hygiene in general. Um, any prosthetics, hearing aids, uh, piercings too, dentures, all of that should be removed for surgery. So phase two, it's gonna include our actual surgical team, right? I did not list the surgeon, CRNA, or anesthesiologist on here, but these are some of the team members of the surgical team. And then here's some diagnoses that you might see. This risk for latex allergy, it could also be like latex allergy. Like if someone has spina bifida, we can't use latex on those individuals if they're going in to kind of fix that sac on their back. Posturing is also going to be important for patients. And then, we want to also, it's cold in the OR, so keep these patients warm. Um, Anesthesia does a lot. They look at the patient's airway and stuff. There's also perfusionists, like in the event of like a cardiac surgery. Um, they basically run the heart for the patient. And then all things, they need to be documented accurately down to the last gauze pad that you used, right? Because we don't want anything getting lost in the patient. Everything has to be accurately reported. So, um, there's a few different types of anesthesia. You have general, which you're fully out. These patients get intubated. Sedation, they're pretty relaxed. Regional is a large part of the body or an area has been numbed. And then local is like lidocaine. So, for the kind of post-surgical care, airway, breathing, circulation, very, very important. It's always your ABCs. Make sure too that you are also you want to assess their level of consciousness. It sounds silly, but we can't visibly see their blood, that doesn't mean that they're bleeding. They're not bleeding. Especially dependent on where they got their surgery. Um, Pain control and vital signs are also going to be really, really important for these patients. So make sure that you're monitoring their respiratory rate, their blood pressure, for any signs of like hemorrhage, or shock. So, also, um, for the like discharge, um, they should have, before going into the surgery, kind of have a little bit of an idea of what the discharge teaching is going to be like. But make sure before they actually get fully discharged that you do make sure that they're aware. And then for the impaired airway clearance, incentive spirometry. So we're not going to give an incentive spirometer to anyone who had brain surgery because it can increase intracranial pressure. But if they had abdominal surgery or like heart surgery or something, it's okay to do incentive spirometer because it's going to help prevent atelectasis. So also malignant hyperthermia, it happens in certain individuals, like where we live, Lumbee tribe, they are more prone to getting malignant hyperthermia. So it's a sudden rapid rise in temperature, like very rapid rise in temperature, and it can lead to severe muscle rigidity. Um, but there's a little mnemonic at the bottom of how we treat it. Um, and some discharge teaching, again, they should have a little bit of idea before they get their surgery. But make sure, after the fact, you tell them if they have to do any wound care, if they have any limitations, and what medications that they need to take when they're going home. If you need referrals like for PT, OT, or home health, make sure that you do that before they leave. And then again, before they leave, make sure that you have fully evaluated your patient and made sure that, their mobility and their functional, it sounds silly, but like 24 hours after someone had a major hip surgery, we want to try to get them out of the bed, because it's going to help prevent post-op complications too, like DVTs. and then it helps bring back mobility to those individuals. All right, and that is everything for today's lecture. I wanted to thank you guys for bearing with me, and I will see you in the next one. Bye.